So here's how this is going to work. So Roberta is the keeper of the questions. So Roberta will provide the question that was asked, and then I will do my best to answer the question.
Okay. And just to follow up, this won't be your only time, needless to say. There'll also be tomorrow. And we just have a couple of questions, so I'll start off, and one's a comment. So the comment is, it's interesting you promote the uniformity of data and understand its importance, but don't necessarily practice it with the quality measures across the various programs, the 5-star, the QRP, et cetera. Uniformity with the QMs would be appreciated.
Okay, so let me see if I can answer the question. I think what the questioner or the commenter is saying is, you talk about uniformity, yet you have different applications of measures for different purposes. Well, that's true, we do. You're right. In way back when, in 2009, the Falls with Major Injury measure was developed for the long-stay residents. It is obviously an important quality measure. It is obviously certainly not unique to long-stay residents. It's actually a measure that's wholly appropriate in other settings. And when the IMPACT Act was passed, remember the IMPACT Act requires a measure in the domain of falls with injury. And so here was a measure that was reliable and in place, and certainly for SNFs, did not add any extra burden. So there are measures that may be, and it's applied uniformly, and there's no risk adjustment and so forth. So there's an example of a measure that is applied uniformly across multiple programs. And so I just want to kind of put that into one space. And then the other is that, yes, there are measures that have a sort of a uniform core to them, but require risk adjustment and appropriate risk adjustment depending on the provider type. And so I think that everyone would agree that that's an important feature to have is the ability to risk adjust appropriately across the provider types. And in fact, the statute, the IMPACT Act law, necessitates that the secretary take into consideration appropriate risk adjustment where it's necessary. So, and then thirdly, there are different reasons for different programs to be implemented by law. And in this case, for the SNF Quality Reporting Program, it's really one of the last provider types to have a statutorily required quality reporting program with a penalty for failure to submit the data. So it was coming, but there are limitations based on statute with who can be sort of in the data collection, which is what we were just talking about, with the Part A stays. Now, can CMS, go through, rulemaking and expand to all payer? We certainly have received feedback in the past about that, suggesting that, but those things take time, and rulemaking takes time, and I think we've been, obviously taking that into consideration. So yes, there are measures that can be applied uniformly. There are measures that it would be inappropriate to simply throw them down in an absolute, exact same way with exact same everything. And it's really the data that tells us, don't do that, or public comment that we've received that says, wait, don't do that. But where we develop quality measures for the IMPACT Act, and the items that are used to calculate the measure, those items we have worked very hard to, at the atomic level, at the data element level, to have them read variable exactly the same. Nursing, and in the MDS it will say residents, and the LTAC care data set it'll say patients. We have driven ourselves mad. Do we say beneficiaries? Do we say persons? Do we say residents? Do we say patients? But really, in reality, we get advisement from our IT advisory team between ONC and CMS and experts in the field that say, it doesn't really matter. So if, folks with the skilled nursing facilities tend to use the word resident, and the LTACs use the word patient. It's really not a problem. It doesn't jeopardize the ability to send information backward and forward. So that's part of the evolution. You know, not all of this can be just stood up immediately. This all is a progression that takes time. So I hope I answered or at least responded to the comment in a way that was helpful and informative.
Okay, let's see. Go down to the next question. Okay. This two-part question. Is there a minimum number of PPS assessments submitted in order to calculate the SNF QRP QMs? Example, when a SNF that has a very small Part A census.
So trying to sort of dissect the question, if you have a SNF, if you are certified and you receive the SNF Part A PPS payment, you are required by law to submit the data as required. And so whether it's one person, you got to submit the data. Now, what assessments have to be submitted is dependent on, on how the measure is calculated. Well, what's the minimum assessments necessary to calculate the measure is dependent upon the quality measures. But the law also speaks to the submission of the standardized assessment at least admission and discharge, or more frequently as necessary and required by the secretary. So I guess the answer is yes, you have to submit. If you have a SNF Part A stay resident, you got to submit the data. And the calculation, how many assessments or what assessments are used to calculate the measures depends on the measure. So I hope I answered that.
Yep. So part two of the question is a Part A PPS discharge assessment required if a resident transitions payers to a Medicare Advantage plan?
Yes.
Okay. That was short and sweet. Okay.
Yes.
If a resident changes from Medicare PPS to managed care, is an end-of-stay PPS assessment required? Yes. Okay. We actually received a question in regards to discharge goals for GG, and we promised that question will be covered tomorrow when Ian talks about section GG. And then I think this is almost close to the last one. Could you please clarify the time frame for the look-back scan for this measure? Is looking at the data, is looking at the set quarter review, October 1st through December 31st. So if a resident had 3 Medicare stays during the quarter and had a fall with a major injury coded on an MDS in each stay, that would be 3 towards the numerator, correct?
If the question is, because I thought I had this and then I got lost. So if the resident was admitted 3 times and they fell with a major injury each time, now think about that. It's a problem.
Really bad day.
Problem exists for a lot of people. And of course, mostly this resident. So it's not resident driven, it's stay driven. So if you want to sort of subtract the name, right? If it happened every time. If it happened one time, and when we go to calculate this measure, we will look, we'll get all the data in and look at all the stays, right? We're tracking by stays. If it happened one time, we're not going to reapply it every time that they were in a stay. If they fell once and you took corrective action and they came back and they did not fall again, that's a good thing.
Okay, and I think that was everything for today.
Okay.
There's like 1 or 2 we're going to follow up on. But
All right. Well, on behalf of CMS, thank you all for spending the day with us, and to our fantastic presenters.